Yeah, would be better.
Yep.
Test, test.
Okay. All right. Can we please get everybody back to their seats? We have Dr. Schneider sitting here. Yeah, can move this over.
And then I would agree with
Thank you so much. All right. Perfect. Can everybody please take their seats?
I'm good.
5, 4, 3, 2. Please, everyone in your seats. All right. Okay. Thank you so much. So we're here with Dr. Michael Schneider. So great to meet you. Dr. Schneider is a chair of the Department of Genetics at Stanford University, and he's a leading voice in precision health and personalized medicine. He is known for pioneering continuous deep biological monitoring, including tracking his own molecular data and detecting early signs of type 2 diabetes before standard tests. He is the author of Genomics and Personalized Medicine, What Everyone Needs to Know. His work is helping bring earlier, more individualized detection of disease into clinical practice. Thank you so much. Very excited to hear from you, Dr. Schneider.
Okay, well, it really is a pleasure to be here. First of all, I apologize for sitting down. I actually lifted some logs that were a little bit too heavy 2 weeks ago. So anyway, I've crunched my back a little bit. But anyway, it is a pleasure to be here and tell you about at least some of the work that we're up to. I'll start with what motivates us, which is that we think the healthcare system is broken. Just out of curiosity, how many of you have been wronged by the healthcare system over the years? Yeah. That's all? Oh, not everyone, huh? Some of you are too young, probably. But yeah, there are many ways in which it needs to be fixed. I'm sure some of the speakers you heard this morning will give you their opinions. We think the biggest problem is that we're very focused on sick care rather than health care. And the consequences, we tend to keep people alive rather than healthy. But even when we practice health care, it's a pretty antiquated process when you think about it. People typically get in a car, always at an inconvenient time to travel to a physician's office. When they arrive, the office hasn't changed that much over the last, say, 40 years or so. There are some new gadgets, but compare that to dentistry, where you can get same-day crowns and diagnostics that have just moved at lightning speed. Medicine has moved, but it just seems to move a lot slower. When you're in the physician's office, they'll draw blood, and from all that blood and time you're there, they actually don't make all that many measurements. And then from those measurements, they treat you based on population averages. So our lab's been focused on trying to change all of these steps. I'm going to focus on just one domain, although after listening to this morning's discussion, I'll just throw out one comment. We just published a study 2 weeks ago. We do very, very deep data dives on people, including the latest study was we profiled people from around the world, and we did find that South Asians living in the US have a younger biological age than South Asians still in South Asia. So moving here does give some health benefits here. And there's a lot of other fun things. The South Asians actually expose more pathogens actually than other ethnic groups, it turns, regardless of where they're now living. Anyway, those are just fun things, and talk about that at lunch or something. Anyway, what I did want to focus today is on diabetes. That is the theme of this morning's session. And I'm sure you're all aware of this. I'm going to give it from the US perspective, not necessarily South Asian, which is we have a diabetes endemic that's worse than the COVID pandemic, in that 11.6% of people are diabetic and 20% don't know it. And 80% of people are pre-diabetic, and something like 85% of those don't know it. Yet most of them will become diabetic. And so we think we need to do something about that. And I'm a big believer in keeping people healthy versus treating them once they get ill. And we think that these new monitors, continuous glucose monitors, are very, very powerful for actually changing behavior. And so I don't know, how many of you worn a CGM here? Wow, This is an enlightened crowd. This is amazing, right? You don't usually see this. In fact, I just gave a talk to a room of about 250 people, and only one person raised their hand. That was in Toronto. It's kind of interesting. Anyway, I'll tell you about our experience with these, which is that they had come out originally, as you may know, for insulin-dependent type 1 and type 2 diabetics. That we just started putting, because we're in the health monitoring, we put them on so-called normal people with normal glycemic control, as well as pre-diabetics. And we discovered that some normal people are, in fact, quite good in their glucose control. Oh, just in case you don't know, you put these on as a patch on your arm. They measure your glucose every 5 minutes. And so some people are normal, do have good glucose control. Some are moderate glucose spikers, and some are severe spikers, just as bad as diabetics, but they didn't know it. We think it has to do with how they're diabetic. I'll talk about that in a minute. And so we went on to actually classify people into what we call glucotypes based on their spiking and glucose levels. We then discovered, as at Aaron Siegel in Israel, that different people spike to different foods. So you've seen about different patterns of diabetes earlier today, but actually the food people eat, it's very, very personal. And so this is the latest study we did in the lab done with Tracy McLaughlin, where we had 55 people eat 7 different carbohydrates. It's identical amounts of carbohydrates, but the forms are different. There's beans, berries, bread, grapes, pasta, potatoes, and rice. And they did it in either duplicate or triplicate. And it turns out that most people are like this. The red is rice. They're rice spikers. And in fact, for most people, rice is worse than ice cream. It's quite glycemic. This person, though, is a potato spike or pasta spiker. This one's a potato spiker in yellow, bread spiker in blue, grape spiker in green. What's going on? Well, we think this relates to the theme you heard earlier, that there are different forms of diabetes. It's not simply type 1 and type 2, but we're coming at it from a very different angle. And in fact, I'll walk through this in a second. But the bottom line is that, there are many organ systems, your pancreas, which makes insulin, your liver, your muscle, your intestine, even your brain is a major glucose consumer. And on top of that, there are many signaling pathways as well. There's insulin, comes from the pancreas. There's glucagon, also from the pancreas. GLPs, these are the incretins, or, well, GLPs you probably have all heard of these days. I won't ask how many are on there. You probably will raise your hand again. I'm on them as well, actually. So, and I'll explain. I'm actually a type 2 diabetic. We'll get into that. So we think that because of this heterogeneity of different organ systems, different signaling pathways, this might be what's going on as to why people are different in their diabetes. So this is ordering so-called normal and people in blue and pre-diabetics in yellow, and a diabetic even snuck into the study. This is their glucose levels by hemoglobin A1C, and we typed them for muscle insulin resistant, hepatic insulin resistance, beta cell defects you've heard about earlier, but there's also incretin defects you can have as well. So we do these very expensive long tests for this. And what we discovered is that everybody's different. First of all, just looking at the pattern overall, they don't look the same at all. And I'll walk you through 2 examples. This person is, let's see, I think that's pointing here. It's muscle insulin resistant, pretty normal or intermediate for the other things. This person has a severe incretin defect and is insulin sensitive. So again, everybody's quite different. And not only that, for those of you who've worn your glucose curves, you may have looked at the shape of this. Now, this is a shape after drinking a shot of glucose. And even still, it's one simple thing, glucose. The curves are quite different. And we suspected that this was due to the heterogeneity of diabetes I just mentioned. And we wound up using machine learning programs. You can see, for example, this one rises fast, slow fall. Let's see, this is more symmetrical, medium rise, medium fall, double humps, etc. And we used machine learning and AI to predict people's subtype of diabetes just from the shape of this glucose curve. And it works pretty well for these 2, muscle insulin resistant beta cell defect. Doesn't work too well yet for these. We're still trying to improve our models there. We'll probably have to bring in other data types. But nonetheless, it does work. And what that means is that instead of taking many, many hours to do these tests and thousands of dollars, you can now do this for basically a $50, CGM you can buy and drinking a shot of glucose. So we think that we'll now be able to subtype people very, very inexpensively at home with these CGMs. So what? Why do I care about my subtype? Well, that determines the foods you'll spike to. So for example, if you're muscle resistant, you'll be a potato spiker and a pasta, the one in gray here, but not if you're insulin sensitive. And if you have a beta cell defect, you'll also be a potato spiker. So we're still more to sort out here, but we're trying to match the foods with your subtypes. Not only that, you probably heard you should eat your salad before your French fries. And that generally is true, but that also depends on your subtype. So for example, we had the same people either eat egg whites, which is protein, fiber, pea fiber in this case, or cream, not ice cream, but cream, which is fat basically, 10 minutes before they ate their white rice, which I mentioned actually does spike most people. And incidentally, East Asians spike much more to rice than non-Asians. Another group discovered that first, and we confirmed it in the study. So it's, so I don't understand the basis of that. I think it's quite intriguing. Nonetheless, back on this mitigating spikes by pre-eating, well, it turns out if you're normal, you can actually suppress your rice spikes with fiber and protein and a little bit with fat. And the same is true if you're muscle resistant. But if you have if you're normal, but if you're muscle resistant or have a beta cell defect, it doesn't work, meaning you don't mitigate those spikes. And we still have a lot more variables we're working out to try and work all the rules out for this, for what foods and conditions will spike which conditions. We've taken this one step further. We've had the same people wearing a CGM, a smartwatch, so we can track their activity. They're doing food logging and such, and they're subtyped. And so what we're trying to do is actually correlate what people do as well as when they do it with its effect on their glucose and other actually biological parameters. And once again, you can use AI, and I'll just show you two simple examples here. So this is glucose levels by hemoglobin A1C. Some of this is well known. If you eat your big meal first thing in the morning, you have lower glucose than if you eat it late at night. If you eat starchy vegetables, higher glucose, but fruits, lower glucose. Most people don't sleep enough. You heard that mentioned earlier. If you sleep longer, you'll actually have lower glucose. And there's other things up here too. If you're muscle resistant, you get more benefit for exercise if you do it in the morning, whereas if you're insulin sensitive, exercise is better in the afternoon. So we can, again, start matching behaviors with timing and what people do. We can also take this to look at its effect on subtypes. So if you're muscle resistant, exercise actually improves that. More exercise lowers that. And similar for other things as well. And it turns out if you're a beta cell defect, it does have an effect, but it's not as good. Now, I am actually a type 2 diabetic. You may not guess that. It's not unlike a lot of South Asians, actually. And it took me a while, but I finally figured out I was a beta cell defect as opposed to muscle resistant. I was barking up the wrong tree. Nobody ever looks at what tree you're actually looking at, to be quite honest. But anyway, so I used to be a runner, pretty regular runner, but my glucose kept creeping up. So I shifted from running to weightlifting. I do whole body MRIs so I could quantify this. I gained 10 pounds of muscle mass and it had zero effect on my glucose. And that's because I'm a beta cell defect, right? It doesn't matter how much muscle I have. It's not going to help insulin get out of my pancreas. So knowing your subtype we think is important. It also turns out I'm a metformin non-responder, but actually respond well to these Prandtl derivatives. They're things that promote insulin release from the pancreas. And I actually respond very well. And these days I'm on GLPs like possibly half of you. And it works really, really well for controlling my diabetes. Now, in my case, it's causing weight loss, which I'm trying not to do. I don't want to lose any more weight. And it does cause muscle mass loss. We've quantified that as well. So anyway, but it's helped my glucose a lot. I went from 8.5 or actually 8.4 to 5.7 actually, just by going on GLPs. And these days I use combinations of things. for other reasons. So I'm always playing with my control. So anyway, you get the idea out of this. So your subtype determines what foods you should eat, what foods will mitigate your foods that spike you, as well as the drugs you should take. Now, we've gone on, I won't spend much time. I forgot to tell you, I'm conflicting in everything I'm telling you because we spin off lots of companies. This company, January AI, basically, you wear a CGM. These days, they can predict your glucose without a CGM. And then they learn from, if you are wearing a CGM, and they'll tell you what foods to eat and not eat. It actually works pretty well for Indian foods, we discovered. Even when tested in India, there's a company I'm affiliated with that's actually running, using their food logging. It's a visual app. Anyway, it works pretty well. And people who do their program, they'll teach you things like, if you are going to eat something that spikes you, do a brisk 15-minute walk. You may know that already, but if you don't, highly recommend it. It works really well. Maybe I'm not necessarily recommending this, but wine will suppress your glucose spikes. I'm not recommending drinking wine for morning, lunch, and dinner. Well, I'm a red wine drinker because I like the polyphenols, and there's a lot more in red wine than white wine. So I'm sure both work, but anyway. All right, so anyway, people do this program. They improve what's called their time and range from the CGM, and they also lose weight, which is not the main goal. But if you are eating better, you will lose weight. The other thing we're working hard on is, again, pushing this idea of remote monitoring. We do a lot with smartwatches. I didn't get into this. In fact, I'm wearing 4 of these things right now, 2 rings and all this. And we can tell you when you're getting ill from respiratory viral and a few other things before you know it, because your heart rate and heart rate variability shifts. Anyway, for this one, we're trying to actually bring home biochemical sampling, where you basically, give little drops of blood, either from your shoulder or your fingertip, overnight it to the lab. And these days, we can make 7,000 measurements from this drop of blood using the deep profiling. Now, I know what that sounds like, but ours actually does work. It's not a hoax. So anyway, we've done all kinds of fun experiments here. And I'll just show you a few. It's this personalized response. So we had 32 people drink the shake, and hundreds of molecules change. We profiled them before and then various times after. They were fast when they did it. And what you'll notice is every box is a different person. I'm just showing 3 carbohydrates up here. For this person, their carbohydrates goes down relatively when they drink the shake. For these people, it's up, some quite high. This one's flat, this one goes down, this one goes down. Informatically, we can classify people into 5 groups. So these 5 categories here, and these are classes of molecules in the different colors. So gray is the average of all 32. Brown are inflammatory markers. For this group of people, their inflammatory markers goes down when they drink the shake. For this group of people, it goes up. Same with that one. Same shake, pro-inflammatory on some, anti-inflammatory on others. 10% of people in the US have irritable bowel syndrome. Most have no idea what's causing it, but we could actually measure it with this kind of assay. So this sort of thing we're doing now, we're trying to develop other technologies for that as well. This is what I call the ultimate experiment. This is one person who gave basically one of these microsamples every hour for 7 straight days during waking hours. And the idea, once again, is to correlate what they do and when they do it with their both physiological and biochemical responses. And so what you find is that there are essentially thousands of associations between, say, people's heart rate, glucose, and activity steps. These are cytokines, so immune markers. These are lipids, and these are metabolites. You find all kinds of fun stuff. And there are things you already know. You can see that insulin C-peptide goes up after glucose, as we expect. But we can quantify this, which is nice in this person. And then here's a fun one, too. Alpha-synuclein, which is involved in dementia and Parkinson's, also shows an interesting pattern. We think it correlates with stress. And so the hypothesis is that if we could get people to control these spikes and reduce them, perhaps they could actually push off getting dementia and Parkinson's by a behavioral modification program. At least, I'm not saying it's going to cure them, but hopefully it would help them. So one question I get asked a lot is the stuff we do is super expensive, not the CGM, that'll get very cheap, but mostly omics profiling. And so how are we going to get that out to the masses? Well, the way we do this, Silicon Valley, so we form companies. So we formed 18 over the years. The ones in boxes spin off from the health monitoring work I told you about. I want to tell you about this one. This is the microsampling company that gives little drops of blood. You give it, you take the test at home, you give the samples at home, mail it in, and they'll measure 650 metabolites spanning 20 wellness categories. Now, these categories are basically things like oxidative stress, inflammation, longevity, bone health, heart health, not shown here. But there are things, and the markers they use, they are scientifically validated. They're just not the typical ones you'd use in a clinic. And usually there's multiple markers tracking these things. And this one's pretty fun. We do a lot in aging, as you may have guessed from an earlier comment, and we can actually look at people's biological age, which is not necessarily the same as your chronological age. So as an example, this person is 53 in their biological age, but their age in terms of years on the planet's 51. And if you break it into the various categories, we call these ageotypes. You can see their inflammation's not bad, a little bit younger for their age. Metabolic age a touch older, but their heart age is a lot older based on a number of markers. So you can actually, again, break this down. And of course, what they do is they use your data and any information you give it, as well as scientific data, and they use AI to basically make very specific recommendations. So not just exercise more, eat better, but you should eat these things that will help your heart health or your inflammation or what have you. Some of the things are things I've never heard of, but 95% of people who do take the test do improve their markers. I'm not saying they're younger, but they certainly improve their metabolic markers, which we think is important. So where is all this going? Well, I think we will hit a world where we're doing remote monitoring with wearables like CGMs, as well as, I hope, giving biochemical samples at home. So people really do monitor themselves a lot more frequently instead of just showing up at the doctor every 2 years once they're sick. So we could practice in principle of true healthcare. So what I told you about then is CGM identifies glucose dysregulation that will be missed by traditional approaches. People do spike to different foods, and we can subtype that. And the remote microsampling, we think, has the potential to really also make a lot of measurements that will keep people healthy. This is my lab, an amazing group of people. These are the ones who did the CGM. These did a lot of the microsampling. These did a lot started the wearable work. And this is my long-term collaborator on the glucose work. And I think I saved a little time, I hope, for questions. Thanks.
Insights. Okay, can I just ask, does anybody have a question right now that they just really want to ask?
One from over here.
Okay.
So I'm just curious about when we talk about the significance of CGM spikes, if you're looking at areas under the curve, to kind of help distinguish just the breadth of the spike versus, the insulin resistance, and also, is there anything that you're doing to distinguish just because something has a spike, a food might be healthy, independent of whether it causes a spike. And so, for example, beans have like a second pass effect, right? So they might have a high spike now, but then the next meal, you might have a lower response. So I'm curious if that's.
Yeah, you're raising a lot of great points. So we think the area under the curve is more important. Fruit spikes are usually very transient. And if you actually do any strength training, which I'm a big believer on, it's unfortunately probably, it's not exactly how I hurt my back. But anyway, that'll also break down your glycogen and cause a spike. But that's still good for you because you're causing controlled inflammation, which actually helps you build muscle mass, which is useful. So it is true not all spikes are necessarily bad, but these long, prolonged ones are probably not so good. So we think area under the curve is more important than the magnitude of the spike, although people aren't necessarily looking at that. A lot of people use something called time and range, where they make these assessments about what your range of glucose should be, and then which is sort of an area under the curve kind of metric. So we think that's it certainly correlates better with certain things. And I will say that the spiking, the amount of the time in range is very associated with hemoglobin A1C, but also these spikes are correlated with cardiovascular events, which are independent of diabetes. You can see this. So getting excessive spiking, we think of the prolonged kind, is not healthy in the long run. Yeah, I don't. Do you want me to call folks?
What is considered prolonged? Like, what is that mean?
Oh, I don't know. For the moment, just use area under the curve if you're comfortable with that, or time and range. There's a lot of, it's a little more complicated. People worry a lot about, and I don't know if this is true in South Asian populations, but hypoglycemia. So because you tend to overcompensate if you have some insulin problems or muscle insulin resistance, I should say, you'll make too much glucose or insulin, and then you overcompensate, you get too low glucose. Now people worry about that because people can pass out from that. In some cases can be lethal.
Thank you.
Yeah.
I think we'll take one more question.
There's a follow-up, right? So many.
Well, we should probably give someone else a chance in fairness, but I'll be around for at least part of lunch.
My question, Dr. Snyder, is one of the criticisms of the healthcare system is that we don't have a quarterback. Nobody sees the full picture. And I think what you have is amazing data, multiple. Who is going to am I my own quarterback as I get these new sources of data that I'm not familiar with?
Yeah, I think we need two quarterbacks. Everyone should be their own quarterback because you have more time to spend on your health than any physician ever will. And so we need mechanisms to pull these data into people. We built some platforms. We're trying to work, the concierge services are picking up on this much, much faster than common healthcare systems are. And I think they'll be the ones that have these integrated platforms. Time and range should be an obvious thing that feeds right in. I'm a believer that when you're rolling a new health plan, you should be given a CGM because you'll manage your glucose better. So we need all kinds of ways to change the system to make it much more compatible with keeping people healthy. But your physician should get to see this too, I think, although it's up to you to share it with them. And they presumably would use it better. I'll tell you, resting heart rate taken first thing in the morning from a smartwatch, way more accurate than what you'll get in a physician's office, which is always elevated for nearly all people.
One more? Okay. One more question.
Okay.
I know, it's a lot of
It's okay, we'll be late.
Okay.
So
All right.
this is
Sorry, guys.
so Mike, great talk, Mike. I think it was last year you published a pretty well received paper about periods of life that people go through where there are shifts in our metabolism. You identified two ranges of ages that this happens. Has that been looked at in South Asians, or is that something you're going to be looking at down the road?
We are looking at it, yeah, and it's being revisited. Someone actually is raising a criticism with that study that actually, and they're partly right, but we've looked at data. I think those periods are still there, but we are breaking it down by populations, and we certainly know East Asians have those period, at least the peak at around the early 40s. So what Raj is referring to, we saw a peak in early 40s and 60s. And so it does exist in East Asians. I don't know about South Asians yet. We're trying to find that there just aren't as many good studies out there, unfortunately. And you've heard that 5 times today already. So I think we need more of these. That's why I certainly like the first talk.
Dr. Snyder, you brought up longevity, and lots of people in this room think very much about longevity and leading the healthy lives, way into old age. And it's going to resonate with everyone. But is there an agreed measure for longevity? How do you define or measure it, So
Yeah, well,
far-
there is the measurements tend to be for illness rather than for health. And so there's an ARP-H grant, which we were fortunate to get in conjunction with a number of other groups that actually is trying to build a score called Intrinsic Capacity Score. And they've broken this into 5 areas: cognition, locomotion, vitality, which is a very large bucket, sensory, and what's the other one? Psychological health. So depression, things like that. So we've been trying to use a lot of data where people have been scoring measures that should reflect those 5 categories and building a score. See, the one problem with the healthcare system is you can't get reimbursed for anything healthy because it doesn't have an ICD code, which is always tailored to illness. So that's why there's this big push to set up a score for health, so that if you do a test for health, you could get reimbursed for it. And if you make a drug for health, like GLPs, a lot of people like the idea these may actually be longevity drugs. How do you prove that? You need scores, quantitative measures for that. And there's a big push for that sort of thing. Yeah, so I think that there's a lot of active interest in that, not just in this room, but around the world, actually, especially in the US.
Thank you so much. All right, thank you, Dr. Schneider. I actually do have a question for you too, but I'm going to ask my question a little bit later on because it's a little longer. Okay, so our next speaker is Dr. Deepa Sannidhi. She's a board-certified family medicine, obesity medicine, and lifestyle medicine physician at the University of California, San Diego. She's trained in preventative medicine. Dr. Sannidhi helps people prevent and treat disease through lifestyle and integrative medicine. She is a leader in applying the 6 pillars of lifestyle medicine and developed the SLIM program, which uses virtual shared medical appointments and food as medicine principles to support weight and diabetes management. Her work emphasizes that while newer medications are powerful, they're the most effective when combined with sustained lifestyle change, especially in communities with higher risks for early onset diabetes. Thank you so much, Dr. Sannidhi. Did you want to stand at the podium, or do you want to just hold it? Okay.
Yes. Thank you, Nalini. That was a much better bio than I had given you. So yeah, it's a privilege to be here. I'm at UC San Diego, and wonderful speakers so far. Just an incredible symposium. So thank you to the Arogya Foundation for having me here. So these are my learning objectives. Just my role here. Really, what I've found, I end up doing, or why I end up coming to different places to speak is, we have these new medications, the incretins, and there's just been a revolution in the way we're thinking about weight and lifestyle change. And so the question is sort of like, where does the lifestyle change fit, and where do these medications fit, and how do we bring all this together clinically? And that's kind of what I see my role as. So that I have various roles at the at UC San Diego, and so first, to contextualize this, I want to talk about what the definition of obesity is. So it's a chronic, relapsing, multifactorial neurobehavioral disease, and increase in body fat promotes a lot of things, right? So basically, obesity is a disease with many, many causes and many, many effects. And so we often think of obesity as this heart disease causing thing, diabetes causing thing, but really obesity is in fact quite global in its effects. And so this is why we call obesity a disease. It causes things like idiopathic intracranial hypertension. It causes things like polycystic ovarian syndrome. So this is why we think of obesity as a disease. And obesity has a definition, and that definition has been a subject of debate and change, because what happens when you say somebody's body shape is a pathology, right? That's there's a lot of there's a lot of implications to that. So there's been a discussion of this concept of when obesity is risk. And this is from the Lancet Commission on Obesity that recently occurred. And so they kind of said obesity is risk, so preclinical obesity, and then obesity is disease, where there are symptoms and signs of organ dysfunction. And what they do is they incorporate not only the BMI, which we know is a flawed indicator, but also the anthropometric measures that kind of focus on the gut fat deposition, so waist circumference. and of course, in South Asians, we really need disaggregated cutoffs. So 23 BMI for overweight, 27 for obesity, and Asians as a whole. And there are separate cutoffs also for waist circumference. So you're going to see more and more of this. I always think about this as an equity issue when we talk about waist circumference because, sure, we know we're South Asian, but what happens when you have someone of mixed heritage, for example, right? So, we really need a measure that looks at the waist or, that increased subcutaneous fat. You can't talk about lifestyle change really without talking about weight stigma. You can't talk about obesity without talking about weight stigma. And, weight stigma has been something that's been of a conversation in the United States, but actually it's a global phenomenon. It's been looked at in many different ethnic groups. And, we might think it causes misdiagnosis of diseases because, that bias that we might have might cause a physician to attribute health conditions that are related to other causes to somebody's weight. But also, you would think that maybe the shame from having excess weight would drive somebody to eat less and exercise more, but in fact, it is the opposite. And not only is that the case, it also causes people to avoid healthcare. So things like fewer colonoscopies, fewer pap smears. So it's a dangerous thing. It is something that we should be fighting against. There are lots of things that we can be doing, but it's a larger conversation. But I will say, people first language is very important. So person with obesity, not obese person, very, very important thing to do. And also, just really having environments that set people up for success. So, and exercise spaces and clinical spaces that that provide that have enough the right gown size, the right chair size, things like this. Okay, so then I'm going to talk a little bit about what lifestyle medicine is. So lifestyle medicine is this field that, one of my certifications, and it's this field that basically says, lifestyle is the foundation of treatment for most chronic diseases. It is the first line of treatment for many chronic diseases, but that has not really been operationalized. And many physicians actually don't really feel very comfortable using diet, exercise, sleep, stress, social connectedness, and risky substance avoidance, and using those things in patient care. And how does that happen? What does that translation look like? So so that's what the American College of Lifestyle Medicine exists to do, is to actually, increase the uptake of those things. But it's driven by a lot of research. And so, I suspect many of you in this room know what the diabetes prevention program is. And so, this is and in case you don't know, it was based on a research study in 2002 that showed 58% risk reduction for those who had prediabetes to, progressing to type 2 diabetes. It laid the foundation for a CDC-run program called the National Diabetes Prevention Program that is in fact covered by insurance because, because it showed that improvement. It was so effective, in fact, that it the study was stopped early, and then all three arms, the placebo, metformin, and intensive lifestyle intervention, were then given the lifestyle change, and then those people were followed over 22 years is the most recent data that we have, and there's another decade or so following. Dr. Kanea's colleague, Dr. Araneta, who's at UCSD, is a PI on that, a site PI on that. So it's their goal is 5% weight loss, 150 minutes of moderate to vigorous physical activity. And what's interesting is after that 22 years of follow-up, we really started to see convergence of those various groups. Now at this point, you don't really see that diabetes prevention benefit after 22 years of all those people having been given that initial lifestyle change. But you do see persistent diabetes prevention despite near complete weight regain. That's interesting to me. From the DPP, yes. So other unexpected findings in the DPPOS. So extensive why were there these low CVD? Why was there no difference in the CVD rates, right? So there was in the lifestyle intervention group, there's actually lower use of statins and diabetes drugs. And so talking about GLP-1s, it does make me wonder, like maybe there was a therapeutic inertia we ought to have given those people, and I have patients who I've seen this play out. I want to focus on the lifestyle. I don't want to take the statin, right? So we need to be aggressive with cardiovascular risk reduction. And also, also important to know, DPP was not powered to detect cardiovascular disease outcomes. Dr. Kanay pointed out that DPP was not as effective in South Asians, unfortunately. And there were multiple studies. So this is the Indian DPP, about 29% risk reduction, 26% risk reduction. Informally called DPP2, we had 36% risk reduction. This group was followed for 5 years. We had 30% risk reduction at 5 years. So I think that's non-trivial, even though it's not as effective, right? And then there are multiple other, however, interestingly, when these studies were made larger, you had 11, 12% risk reduction. So, lower numbers there, right? So, I'm not going to beat this to death. We've talked a lot about lower beta cell capacity, but basically, we have limited capacity for subcutaneous fat storage, and then that causes fatty deposition in other organs, fatty deposition in muscle, fatty deposition in pancreas, fatty deposition in the heart, fatty deposition in the liver, very importantly. So DPP, many of you have heard of. Look Ahead is another very large study that informs our, based on the diabetes prevention program curriculum, 7% weight loss, 175 minutes of moderate to vigorous physical activity. People were treated, actually, those who didn't achieve the 5% weight loss, they were given Orlistat, which is a weight loss drug. And this also did not show cardiovascular benefit, unfortunately. Okay, what do we make of this? Should we not give any lifestyle intervention now, right? So, when you look at the sort of the poor self-reported general health folks, they basically were the ones who rendered the study neutral. But if you look at the 85% of the study population that had good self-reported health, they actually did have improved cardiovascular disease risk reduction. And those who, interestingly, lost greater than 10% of their initial weight reported 21% reduced mortality. So, there is a mortality benefit to lifestyle intervention. Other lessons, 11% for whom prediabetes remission was achieved, so normal glycemia, you had a risk of cardiovascular disease death and hospitalization by more than half reduced. And fewer medications. You had the same risk reduction as the control, as metformin on fewer medications, right? So imagine if we had provided that medication, in addition to the lifestyle. And so I'll stop there because I'm in the interest of time. But pounds lost study. So this is just like Diet Fits that Dr. Gardner was talking about. Really confirmed. This is an older study that really it's not the macronutrient breakdown. It's very much the adherence, in fact, that matters the most. So what is it? So this is now we're starting to get into this area of what does an effective lifestyle intervention look like, right? And when we look at these lifestyle change studies, large lifestyle change studies, what can we expect? About 4 to 6% weight loss. And, in general, we say 5 to 10% expected weight loss. So when, it's really, when we're talking about lifestyle change, we do not want to talk about testimonial level lifestyle change expectations, right, with weight loss. We want to have realistic expectations with lifestyle change. So these inform recommendations. So the United States Preventive Services Task Force is our gold standard for preventive services recommendations. And the last recommendation that we have around this is from 2018, their statement in 2018, which is under review at this point. So this is giving us, this says that, anyone who has a BMI of 30 and above, so for us, BMI of 27 and above, refer to intensive multi-component behavioral interventions. So what does that look like? And there are other recommendation statements as well that say that we really ought to have intensive lifestyle intervention for people with various health conditions, including those with impaired glucose tolerance and cardiovascular disease. This is, just kind of looking at different ways of, what are the different indications. For South Asians, okay, what does that look like? This is a very small study, actually, the SHAPE study, 17 people. But what I liked about it is, besides the fact that 55% of the 17 people that they had regressed from prediabetes to normal glycemia, what they did is they actually used focus groups, and they did some community listening to tailor the intervention. So, I love the fact that the South Asian Health Study has been, doing this in an iterative fashion. But, and they've been doing a lot of what Dr. Kanea was talking about with regard to the diet, right? Like reduce the ghee, reduce the white rice and things like this. But also physical activity, they elicited from the participants that these people lacked a baseline. The participants felt that they lacked a baseline exercise habit, and they needed foundational instruction, foundational kind of guidance to improve physical activity. And for women, there were expectations around modesty, lack of access to women-only exercise spaces, and competing family caregiving priorities. So they did have an improvement in their physical activity, and they also addressed body image, food and social roles in community settings, trying to bring in, all these things. So this is for this is for South Asians. In general, according to the recommendations, according to USPSTF, we want to have 8 sessions over 12 weeks, greater than 12 sessions per year, 6 months. Often the programs last 6 months to a year. They can be delivered by physicians or trained non-physician staff, and should include diet, physical activity, and evidence-based behavioral strategies. So diabetes prevention program curriculum is one. There's also model IBT specifically for obesity. And this is really important, because we don't really give enough importance to what does an intensive lifestyle change program look like. And it's important to remember that this is not for South Asians specifically, right? And I'll talk a little bit about that. But imagine giving someone 2 milligrams of atorvastatin and saying, oh, like we gave them 2 milligrams of atorvastatin, their cholesterol didn't go down. Then I guess cholesterol medicine doesn't work, right? Like we have to give people the appropriate dose of lifestyle intervention. So this is just not the narrative review that I co-wrote along with some other leaders in the field related to lifestyle medicine for the treatment of obesity. So if you're interested in kind of looking at what lifestyle intervention looks like in obesity now, this is something that we just have it's open access, lots of useful tables meant to be kind of a handbook. So besides the session cadence and things like this, what should a lifestyle change program look like? It should have evidence-based behavioral treatment. I could spend an entire day just talking about this, but really, these are the components of evidence-based behavioral treatment. And you want to be very action-oriented and specific in your goal setting. This is my program, the SLIM program, and we use shared medical appointments because access to, insurance-based access to intensive lifestyle intervention is a challenge. We've used we've operationalized CPT codes used for office visits for providing that intensive lifestyle change. So this is the structure of my program. We have 12 visits in a group setting, and we have 3 initial visits and follow-up. And the follow-up is really focused on making sure that people have that maintenance support. We use volumetrics, so kind of reducing calorie density. So this is from Barbara Rolls's work, incredible woman, that I really look up to. But if you look at, say, the 600-calorie food, you incorporate increased water and reduced fat, you can make that same food into a 300-calorie food. These are some resources that can be used. The American College of Lifestyle Medicine has a handout on calorie density, as well as the Full Plate Living Program, which is from the Ardmore Institute of Health. They have some really great resources, and all for free. So just other simple concepts, daily weighing. But also framing this, in the clinically speaking, it's, yes, research shows daily weighing is helpful. Self-monitoring is very helpful. But also, we have a large percentage of our patients who have obesity that have disordered eating and eating disorders. So we want to when we're talking about daily weighing, if they have an eating disorder, then that's going to cause weight gain, right? Or it can cause a worsening of their eating disorder. Importance of maintenance therapy. Maintenance is very, very important. So, you don't want to just say intensive lifestyle change and then bye, right? Like we want to also make sure to provide that continued support. And pharmacotherapy also offers superior weight maintenance. So, some pragmatic studies suggest it's possible to support patients in their weight loss with monthly maintenance sessions. So that's an option. And exercise can assist with and augment weight maintenance. Okay, physical activity in those with obesity should really be encouraged for its benefits outside of weight loss. Now, I can't say this is necessarily the case for South Asians, but this is what the physical activity guidelines for Americans at this point recommends. And exercise does not necessarily drive weight loss. Exercise has a lot of benefits. It's important for cardiovascular disease health, promoting weight maintenance, not weight loss, right? So really we should encourage increasing gradually and to avoid injury, and not and continue to encourage, but really important to understand that it does not necessarily drive weight loss. Okay, so now where did GLP? So this is kind of contextualizing where the evidence is, what the expectations are, what does lifestyle change look like. Now where do GLP-1s fit in? Okay, so GLP-1s are these, revolutionary therapies, right? So, we have indications for semaglutide for cardiovascular disease, for metabolically associated steatohepatitis, for chronic kidney disease. We have incredible expectations for 5 to 10% weight loss for lifestyle change, right? 10 to 12% for orforglipron, most recently approved. Semaglutide, 15 to 16% weight loss, 20% weight loss for tirzepatide. And what about and so this is this is the comparison, right? So that 5 to 10% weight loss. Now we have to. Why is that important? Weight regain may be due to persistent metabolic adaptations. So you have to make once you have somebody go through a lifestyle change program, they might have weight regain. They might also have a plateau around this 5 to 10% weight loss. And there's also and in order to impact things like obstructive sleep apnea, fatty liver disease, you need something like 15 to 20% weight loss, right? So what about for South Asians? Okay, so there was there's a meta-analysis just last year, 8 cardiovascular outcome trials. About 30% risk reduction for major adverse cardiovascular events in Asians, whereas for Caucasians, 15% risk reduction in hazard ratio. And then so there's a scientific statement out there: South Asians may exhibit better response to incretin-based therapies compared to sulfonylureas and metformin. So generally speaking, GLP-1s are probably a better choice for us. And there has been a study, for example, with liraglutide that actually improvement in visceral adiposity in South Asian participants. So useful. Okay, so GLP-1s are fantastic. Hopefully I've kind of laid the foundation to say that it doesn't. That lifestyle change is still necessary despite GLP-1s, but can they help? Can they augment? Well, so this is data from the SURMOUNT-3 study. So in the SURMOUNT-1 study for tirzepatide, which provides about 20% weight loss, that's what you saw. You saw 20% weight loss at the 72-week mark. But in SURMOUNT-3, what they did was they took a subset of people who lost 5% of their initial body weight using intensive lifestyle intervention, and then they added tirzepatide. Those people lost 25% weight loss. This is the highest weight loss that we've seen outside of bariatric surgery, except for, I think tirzepatide at 88 weeks was 82 weeks or 88 weeks was what showed about the same weight loss, but that's just a longer follow-up, right? So it's really impressive results. We are going to see higher weight loss than this with upcoming agents, but this is really important. So okay. Also, there might be additive benefits. So this is the Million Veterans Program. So they took out of this roughly million participants, 98,000 with type 2 diabetes that were on a GLP-1 receptor agonist. And what they sort of assessed everyone's lifestyle change habits at one single time point, eight different lifestyle change habits. And they found when these people who were taking a GLP-1 receptor agonist, they were adhering to 8 low-risk lifestyle change habits. There were 60% lower major adverse cardiovascular event, and GLP-1 RA alone, 16% lower MACE risk, right, compared to the non-lifestyle change folks. And those who maybe 6 to 8 low-risk lifestyle factors plus GLP-1 RA, 43% lower risk of major adverse cardiovascular events. So you can see this additive benefit that people have. Okay, muscle loss, big discussion. So, there is muscle loss from GLP-1 receptor agonists. The clinical significance of this muscle loss is not very clear at this point. Muscle quality might be better. We don't know. And well, it is. It is better, but we don't know if it doesn't mean anything. That some people lose weight, lose muscle. So I think higher risk groups are important. Interestingly, people with type 2 diabetes are a higher risk group for muscle loss. Older adults, postmenopause. So we want to try to encourage slow weight loss if possible. We know that rapid weight loss can worsen muscle loss. So, this is something that is being discussed. Resistance, I will say this is not, the evidence is very early on this, right? So this is cautiously provided advice, take with a grain of metaphorical salt, if you will, again. Resistance exercise is incredibly important. So, and more important than protein intake. Protein, we are living in a golden age of ultra processed protein products. So just but I say that somewhat tongue in cheek. I think at the end of the day we have to be practical. Our patients might need the help of those things, but protein without resistance exercise is not adequate. What kind of protein should we be using? 1.2 grams per kilogram of 1.2 to 1.6 grams per kilogram of adjusted body weight or ideal body weight at a or weight at my colleague Michelle Hauser here at Stanford. She uses weight at a BMI of 24.5. So these are and the reason for that is adipose tissue is it doesn't really require as much protein. And so, if you do, now you hear things like 2 grams per kilogram of actual body weight. And this is, think about the calories that you were replacing when what kinds of foods you're using. So this is a graphic from a multi-society advisory that I was involved in. We called it an advisory because it's not a guideline, not an expert consensus statement, but we recognized that there was a vacuum here in terms of, what was it that people should be doing. So, we talked about basically nutritional priorities to support GLP-1 receptor agonists. We talked about the importance of preservation of muscle and bone mass, managing the GI side effects, preventing and mitigating the nutrient deficiencies that could occur. So, really at the end of the day, hopefully I've convinced you that GLP-1 receptor agonists should not be prescribed in a lifestyle medicine vacuum. This is my daughter's first birthday, and we called it the Better World Bash. We focused on incorporating lots of lifestyle change. We had a healthy potluck. And so, I think the importance of community and culture is really key. And hopefully, we can work toward a better future. So thanks, everybody.
You can hold on to this because you're going to still answer questions. Thank you. Okay, thank you so much, Dr. Sannidhi, for this very balanced and insightful discussion. Just kind of talking about the entire integrative approach, I had a question for you on, so there's been a debate around starting GLP-1 receptor agonists early in South Asians before diabetes develops. How do you counsel patients on early use versus long-term concerns? And then do you view GLP-1s as a lifelong commitment or more as a temporary metabolic jumpstart, kind of with an intensive lifestyle change and then titrating off safely?
Yeah, I think the first question is very relevant for you because as a pediatrician, you must be thinking about this a lot. I think it's just like with anything else, it's a risk-benefit discussion. I think if you have, I think it's really important to think about with obesity. Say somebody has a BMI has a weight of 200 right now, and then they gain 20 pounds in 2 months. And now 15% of 200 is going to be 170, right? 15% of 220 is something like 190. So you're starting at a higher baseline now. In terms of what you can come down to is going to be higher. So that carries with it additional cardiometabolic risk. And basically what you're trying to do, and the good thing about, a young person is that they can really increase their exercise and, maximize their bone health from an early age. So I do think that to me, the overall risk benefit is a conversation, but it's definitely individualized, right? You have somebody who's maybe disabled and sedentary, they're going to have a higher risk for bone loss. If they're on chronic steroids, even more chronic, risk for bone loss. So I think it's an individualized discussion. With regard to the jumpstart, I'm really glad you asked that question because GLP-1 receptor agonists are not a jumpstart, and so it's a very important thing to know. The way I frame it is that if you are thinking about starting on a GLP-1 receptor agonist, you should have every expectation that you will be on it for the rest of your life. In practice, that's the research, and not just for GLP-1 receptor agonists, for all anti-obesity medications or obesity management medications, or some different terms. But we see that when the medication is taken away, the weight comes back. So very, very important consideration. And, there's different ways of thinking about this. In the real world, we're starting to see there's some small studies that have, people kind of publishing conference abstracts where they're saying they're seeing in the real world, like, oh, if we wean the GLP-1 receptor agonist down, maybe we're able to keep the weight off for longer. But that still doesn't address the cardiometabolic benefit that GLP-1 have independently, right? We're also seeing people say that they're able to work with their patients to have a less frequent dosing schedule, like maybe every 2 weeks, every month, even for some people who responded really well. So, we're going to find out more about that, I think, once there's more, real world data. But for now, the conversation should very much be, you should expect to always be on it.
Thank you.
What do you
One
do
question.
when you plateau
Uh-huh.
on your so when you're at the maximum dose,
Uh-huh.
and at some point you just plateau? And even if you've incorporated exercise and
Yeah.
lifestyle management, but for someone who looks at food and puts on weight, and you're absolutely right. When I did come off with GLP-1, the weight came back.
Yeah.
So, any thoughts on that?
Yeah, I mean, there's an argument for so it's important to look at what other medications you're on and seeing if they have a weight potentiating effect. So to reduce that, so some really common ones are calcium channel blockers like amlodipine or beta blockers. So those things that we don't even think about, but also it's important to look at. It's also there's an argument to be made for layering on other other weight management medications. There is also for very uncontrolled diabetes, and some would argue even less than that bariatric surgery, which comes with its own risk benefit discussion.
Thank you so much, Dr. Sannidhi. Okay, so we're going to move along. You're going to be here, right? Yeah. You're going to be here for a while. So I'm sure that Dr. Sannidhi will have lots of questions, so you'll have your opportunity to ask her as well.
Leave this here. I don't know how to turn it off.
Okay, that's okay. Me either. Okay. All right. So, So our next session is going to be more of an informal fireside chat between two very interesting women. One is Seema Srivastava, who embodies the power of community-driven health advocacy. Seema is the Global Advocacy and Social Impact Director at Beyond Type 1, where she works to expand diabetes care to over 2 million people globally and build strategic partnerships with international organizations like the World Health Organization, UN agencies, NCD Alliance, and others. She has held senior leadership roles at UNDP, World Bank, Aspen, PATH, and has dedicated more than 25 years to leading transformative change in global communities. Her passion for social impact and belief in collaboration have shaped her journey as a philanthropic leader, tackling complex challenges and driving initiatives that inspire collective action. The other is our own Dr. Nalini Saligram, the founder and CEO of Arogya World. She is an Ashoka Fellow, a TEDx speaker, and a tireless advocate for diabetes prevention. Under Nalini's leadership, Arogya World designs and implements scalable, science-based diabetes prevention programs in schools, workplaces, etc., and has reached 29.5 million people in the community setting over the last 15 years in India. Nalini leverages public-private partnerships and global platforms to improve the world in which we live. She led Arogya to become a 2022 recipient of the UN's Interagency Task Force on Non-Communicable Diseases and the WHO Award for Strengthening India's Primary Healthcare, and the Google AI for Social Good. Nalini and Seema, I'm gonna pass this on to you now. Thank you.
Thank you. We're going to be 30 minutes late. So sorry, guys. It's 12 almost, and we wanted to end the session. This is the last one, though. But it's an important point. So thank you for indulging us. We've had such a fascinating morning. I really feel we've made some history here. And this is the beginning of a annual conference like this. We want to do this every year. I think we need to shine the light more on how South Asians are impacted and all these new things we learned today. And, you know, we just need to modify our own expectations of how we lead our lives, as well as what we can do to influence others as well. So Seema, I really look forward to this conversation with you. We're going to get directly into the topic, okay? We don't have time for a setup because we're already late. I want to ask you a few questions, particularly on the traditional role of played by philanthropy in healthcare. Okay, what have you seen as the traditional role? Philanthropy has a role and has played an important role, but what do you see?
I'm not going to use a mic. I've never used one in my life unless there's more than 150 people. So I'm just going to speak without one. I'm a moving voice. But traditionally, what I've seen is that philanthropy really steps up where systems fail or don't fill the gaps, like funding innovations or reaching underserved populations, or in governments where governments are slow to respond in taking risks. But I do see a shift that is happening over time, where traditional philanthropists are moving away from just filling gaps towards actually funding more systemic spending, right? In type 1 diabetes, which is where my primary work is, it is not, it's lifelong. It is not preventable. So this means increasing access to insulin, to technology, to ensuring that the capacities are built of community health workers and primary healthcare workers to be able to deliver care. Also in long-term programs that can see better outcomes for those living with diabetes. So definitely the shift is more needed and it is coming. I will try.
Okay. So I wanted to add a bit as well. I have been in global health for some decades now, and I have watched sort of several phases of global health: HIV, AIDS, women's health, sexual and reproductive rights, under 5 childhood mortality. All these have been waves of global health that I have actually been able to witness. And what is very interesting is that philanthropy did step up and tackle all those really serious challenges. Okay, just to give you one example, Gates Foundation, definitely made a difference, even in deep remote states in India. It has made a difference to the way women's health is tackled, the way under 5 childhood mortality is tackled, HIV is tackled. This stuff, it does happen. Individual philanthropists can make a difference. What is very interesting now is that I feel technology and nutrition are also coming into the play. Those are also spaces that are being attractive to philanthropists. So it is very interesting. I think diabetes less so maybe, but several aspects of global health are covered by philanthropists. So to diabetes now. For an issue that is so community centered and affects so many of our families so deeply, why has diabetes been chronically underfunded despite the scale of the crisis? You go ahead and I'll add some color.
Well, so diabetes is not a scale problem. It's a visibility and a stigma problem. 589 million people live with diabetes in the world. It causes one death in every 9 seconds. Almost more than 1 trillion global health cost on diabetes, and only less than 2% of development assistance in health goes in NCDs. So really, it is not the lack of resources that is the key for it, right? Part of it is, and I've been hearing all of this, and it's quite a lot about type 2 diabetes, is the basic feeling or framing of diabetes as one size fits all and saying it's manageable, right? To really understand that it's manageable only if you have the right tools, the right technology, the right medication, the right training, and the right support system. We leave out a huge thing that was mentioned about the diabetes distress that people live with. And let's be honest, even for most of us living in privileged communities, it is a daily burden to manage diabetes. In India, where it's got the maximum number of children living with diabetes. Over 300,000 live with type 1 diabetes, and they still don't have access to medication, access to resources. And I give you an example. So, and this goes back to what you mentioned about the Gates Foundation. I used to lead the Gavi program for them in India. So really seeing this very closely. About last year, we got an application from a very small nonprofit working in a district in Jharkhand. And what struck me and sprung out to me was it said, one, that they worked in integrated health, and so diabetes, cardiovascular. They said, the one line they said was, they want to work in this little district called Pakur because nobody believes that diabetes happens to people in villages. It is a rich thing, and it should only be if you eat well, which none of the people in rich people do, is in the interviews that they send to us in the need analysis. That is what is going to happen. Now, over 17,000 people in this little village there, we funded them, and 1,700 came out with diabetes, some at dangerous levels of diabetes, and 111 with type 1 diabetes, of which there was a girl of 7-year-old going into DKA, right? And look at this. To get them diagnosed, she had to work with the government to get 2 blocks to set up a system where 85% of them did not have national identity cards, so could not get insulin or access to insulin. There was not even an auxiliary nurse or midwife going into that district. And so they had to take them to Bengal border in Malda to a primary healthcare center for this girl to survive, which is 38 hours away, through 7 modes of transport, right? So it goes back. And now that we have given them the funding, industry in India has given them support. I'm sure many of you know that the national guidelines for diabetes in children has just been released by India, where you can get free insulin testing. But the reality is far from that, right? So the lived experience is very important in all of this.
Yeah. So I just wanted to say that, the Global Burden of Disease report says these non-communicable diseases, NCDs, she used the word, which includes diabetes, heart disease, cancers, and chronic lung diseases. These diseases are the number 1 cause of death. I mean, there's just, keeps on coming up. 1, 2, 3 reasons for dying are these chronic diseases. Diabetes is not always recognized as a very serious disease. Okay, it does have very serious complications, though. You get heart disease, you get stroke, you get foot amputation, you get eye disease. All of these are complications of diabetes that is not fully appreciated by even governments, which is why there is so little action for preventing this. At the same time, prevention is the smart solution to this crisis. Okay, we know 80% of type 2 diabetes. Dr. Kanaya is not here. Oh, there she is. I don't know about South Asians, but 80% of type 2 diabetes, DPP, WHO, a whole bunch of global landmark studies have shown you eat right, you exercise, you avoid tobacco, you can prevent 80% of type 2 diabetes. And that's 90% of the disease burden, okay? And you can prevent 80% of heart disease. also of great interest to us in South Asians here. So if prevention is the smart solution, why is there so little interest? 1 to 2% of development assistance goes to prevention, okay, in the world. It just defies logic. Number one cause of death. Global studies show that it's possible to prevent, yet you can't prevent. There's no interest in preventing. 1 to 2% is nothing, almost nothing. So we today have an opportunity to call for more action on prevention. And the one reason is the pharmaceutical companies, for example, don't want to invest in prevention because they want to grow the pie. They want more people to get their medicines, perhaps. So, but we need to get lots of stakeholders interested in prevention, even though the outcomes are not going to come for 20, 30 years. Even though you can't see, you can't put your arms around what prevention really looks like. I think that's one of the biggest challenges we have. One is the narrative. One is for me, people to understand that diabetes is very serious. And two, to understand that it's underfunded by everybody. And three, to understand that there is hope. You can do something about it. It's called lifestyle change, even though the jury may be out on South Asians for a little bit. Hey, I think fundamentally, eating right and exercise and sleeping, all these are really, really important, and we must make that happen. So lots of challenges for us. Okay. I just want to take 2-3 minutes more to understand a little bit about what the Beyond Type 1 does. Okay, and then I want to tell the audience here what Arogya World does. Hey, all morning today, we haven't had much interest or it hasn't come up, so I do want you to know what we do. Okay.
Before just talk about Beyond Type 1, let me just start with the premise that you said about prevention. And Beyond Type 1, and we are called Type 1, is because that is how we were founded, because our co-founder, Nick Jonas, lives with Type 1 diabetes. And it was co-founded 10 years ago by Nick Jonas and Julia Dipagani. And Type 1 diabetes is not preventable. It's lifelong, and it's chronic, and it needs to be managed very, very seriously. So really, it was two powerful ideas on which it was founded. The first is that anyone with diabetes should have a life beyond that diagnosis. And the second is it should not be alone. So we really believe that anyone who lives with diabetes deserves the right to have access to care, to knowledge, and to have a full life, so that they can survive and they can thrive. We work across both type 1 and type 2 diabetes. So we do have a Beyond Type 2 as well. And our whole model is based on a combination of storytelling, on digital tools and reach, on educational resources, political advocacy, and community. And I heard before me, the professor from San Diego talk about community. Very, very important for us, and peer networks. So why we are unique is that we don't believe that awareness is the end goal. It is the beginning or the entry point. And our digital reach, which is over 600 million people, is what we use to build awareness. Our community, which is almost 5,000 ambassadors of living with diabetes, are how we build trust, we build action, and we build community and peer support. I heard someone ask, who will be your quarterback? It is your community who will be your quarterback. So we have this 5,000 community who then translate these resources into absolutely contextual, simple languages and toolkits, which then go into the community through our ground of our programs. So our programs in the US are called Beyond Barriers, and we really are closing the gap in care for those with type 2 high incidence of that, and especially in the brown and Black communities. And then in also working with those in misdiagnosis or lack of diagnosis in type 1 diabetes. I lead the international work for Beyond Type 1, and I will speak specifically for India. In India, we give a lot of grants to very grassroots organizations that work to build awareness, educational resources in very innovative and creative ways to reach the last mile. We then also do political advocacy, and we build an ambassador network which can go deep into the community to really talk about type 2 and type 1 diabetes. That really is the core of our work. Just to give you an example, last year we launched the Beyond Type campaign in collaboration with our board member, Priyanka Chopra Jonas. And Priyanka's reach helped us reach 450 million people with that campaign, and translated our work to 3 million people in just 9 months on ground by just the reach that we have. And this is really because of the culture, the community, and the partnerships we build on the ground.
Yeah. So just to give you a flavor of what Arogya World does, we do diabetes prevention through healthy living in India mostly, and we've just pivoted to bringing some of our learnings to the US. We work in the community setting, translating the science from these big landmark studies into on-the-ground programs that are effective and well-designed and work. We've reached 29.5 million people through last year, over the last 15 years. We work in schools, in workplaces, we work through social media, reaching urban consumers where they spend time on Instagram, teaching them what to eat and in what quantities at every meal. We have schools programs where we teach school children the basics of healthy living. What is the importance of eating fruits and vegetables, and we use them to get to their families, to get their families healthy as well. So we're getting traction there in all these programs. We do behavior change. In fact, with Stanford Care, we have published a paper that shows data on the pre-post effects we are seeing in life behaviors of these school kids. These are school kids in rural settings in West Bengal, in Uttar Pradesh, and Rajasthan, and we are getting really good results. We also have a workplace program where we certify companies as healthy workplaces when they reach certain employee health criteria for program criteria in physical health and mental health, and we require them to recertify every 2 years. So 300 companies reach of several million employees is what we have in India. I think we're encouraged by all the feedback we are getting from our partners as well as from these company CEOs and HR leaders. Big companies like Godrej and Tata Consultancy Services and Indian Oil and Bayer and Reliance have become what we call a Hall of Fame healthy workplaces. These are at the top of the heap. They're ambassadors. They believe in our program. We are not a vendor. We are a knowledge partner to all of these companies. So we are on CII, Confederation of Indian Industries, top, public health councils. We also have made as I said, we use Instagram to educate people on my thali, which is what to eat in every meal and in what quantities. Cooked food, again, we go with the cooked food. Today we saw an example of that. And then the last point is entire cities. We make them healthy cities. We call them Arogya cities. We mobilize Bangalore and Mysore have become healthy Arogya cities. We are now in conversations to do that in Bombay and Chennai as well. We're also pivoting to the US, and we're finding our schools programs that were designed, yes, for 11-year-olds in rural schools in India are working here in the US. We have adapted that same program, and it's called Arogya Clubs, to deliver, use high school students to deliver our program to 11-year-olds, Hispanic and African-American kids in vulnerable communities in Atlanta. And we've just finished 1-year program. So there is interest in expanding it to the rest of Atlanta. There's also interest to expanding it nationally. And we're going to, take it up. Here, the South Asian Heart Center is a partner of ours, and we are bringing that same lifestyle change program of theirs to our communities. We have communities in Chicago and Atlanta that they don't have access to. So, hey, nonprofits partnering with other nonprofits is fairly disruptive, okay? It doesn't happen every day. Everyone has their own lane and silo, and I am very excited that we are beginning to make those changes happen. We also have a tool here called My Desi Plate that shows people, and Ashwini was part of it, and so was Minal. We are looking at ways to what do you eat when you eat Indian food and you're an American? Hey, we'll show you what to eat in what quantities, and we have that. It's on our website. We promote it every year. So I also want to ask you. We're in Silicon Valley, Seema. There's incredible wealth here. There's incredible wealth among South Asians here, and I wanted to ask you, what is the role that diaspora philanthropy can play in prevention?
Well, also in funding long-term care. Well, so the diaspora actually really sits as a South Asian who's living with diabetes since the last 15 years, has gone through the entire stigma, misdiagnosis, misconceptions, advice to lifestyle, not giving importance. To me, I see the diaspora really sitting at a very important intersection where there's capital, as you just mentioned, there's professional expertise, and then there is cultural fluency and understanding. Right? And this cannot be replicated at all. Cultural fluency is important because a health solution designed in suburban America cannot apply to the Indian subcontinent. Let alone the urban. Rural is very far from that, right? And this is where the diaspora plays a very critical role. First, in advocacy. So you mentioned, things like the healthy plate and people working in silos. When I walked in, and this is after 25 years of working across 60 countries and a lot of it in India, most nonprofits work in silos. So, advocacy and working as an ecosystem is the first thing that the diaspora can do for us. The second really is, in the funding. So for type 2 diabetes, it would be a very fair ask to say fund prevention models, right? But type 1 has a different urgency, right? And is greater because people are struggling to access insulin, struggling to get trained care, and to find support in community to beat the social stigmas, the social influences, the family dynamics, the diet, all of which the diaspora understands really well. And that is where we need the diaspora to come together to fund these models of long-term care, not to do one-time charities, but to think about long-term care and lived experience solutions. So there are a number of our organizations like Arogya World and us. We came together because Nalini approached us with some of the tools that they have launched in Instagram. We are a highly digital organization. We get a lot of funding, and I also sit on the advisory of a $100 million fund of Aligned T1D, which is, of course, T1D is what it's working for, but it's industry partners like Roche, and it's Lilly, and Novo, and Hemsley, and Breakthrough, which all are coming together to fund LMIC work for type 1 diabetes care and long-term support. And we are looking to Arogya for their invention that they had, or the innovation in a WhatsApp, because India is the WhatsApp queen of the world, right? And how do you get information out easily to people in very simple languages? So really, where you're born should not determine your diabetes outcome, and that is where diaspora can help us fund these models.
Yeah. So, coming back to the wealth of our community and of Americans in general. So, Indian Americans have, are at the peak of their achievements. People do really well here. They are, business leaders. They are philanthropy leaders. And they are stepping up. What was it? Dalberg did a study of 2 years ago, and then they compared results to 5-6 years ago. And Arogya World, we are members of the India Philanthropy Alliance, and the last round was in collaboration with IPA. So what it showed is that Indian Americans are giving, over those 5-6 years gap, they tripled their giving. Okay. So they used to give at $1 billion when the Americans were giving at $5 billion levels, individual Americans. But now Indians are giving at $4 to $5 billion level. Okay, so they tripled their giving in 5-6 years. I think that's very encouraging. Okay, you're not just at the peak of your business achievements, you're also stepping up. I felt, that, hey, we are stepping up and we're doing a lot even in philanthropy. So the gap is still there. We're still $1 billion behind what Americans, average Americans would give. But if we started giving at those levels, we would, be quite a force. $85 trillion is the, yeah, $84 trillion in wealth is intergenerational in the next few years. So we really need to capture that. A good part of that is going to be Indian Americans, and I think we can really make a case for, hey, find wicked problems where you can, get some long-term outcomes. This diabetes is one of them. It's a space that is underfunded, as we have said, and this is a spot where you can make a difference.
Nalini, if I may just add
Yeah.
to something that you just said, is while the funding that has increased by the Indian diaspora, what is missing is the integrated funding and focused funding. So even today in diabetes, the largest funding doesn't come from the Indian diaspora when it is the diabetic capital of the world, second largest diabetes, highest number of children living with diabetes. The South Asian community is known for the diabetes. I mean, I work in projects in India and Africa, especially India, keeping it to India, a large amount of projects of research are through Stanford and through funders, which are American billionaires, not at all by Indians. And that is really a good call that you're making is, we can help tell you where to invest if you would like to know.
So last question, 30 seconds, please, Seema. What do you think a transformational prevention model would look like where individual philanthropy can really play a role?
I think the first thing is to ask a question is what does success look like for you? So what is the outcome that you personally as an individual philanthropist align with your personal need or your personal goal of your organization that you are with? What does that look to you? And then define success, because success is not in diabetes is not one size fits all, right? So for type 2 diabetes, I'd again go back, it's reduction in incidence. So investing in reduction in incidence because it's high, and look at South Asian risk profiles. I saw a beautiful presentation earlier by Dr. Here. And so look at that and see where you can invest in that. In type 1 diabetes, you cannot reduce incidence, right? It is autoimmune. So what is it then? So then let's look at long-term models of care where access to insulin can be increased, where systems can be strengthened. India is one of the first countries to have taken out a policy that every public healthcare center will have test strips and insulin. Is that really happening? Right? We work closely with the William J. Clinton Foundation. It's only in 2 states that it's happening, right? So really, global commitments exist. The UN political declaration in 25 said that by 2030, 80% of the public healthcare facilities are going to have essential NCD medications, right? The gap is in delivery. And that is the gap that transformational philanthropy really needs to be catalytic in filling. And I have really 2 things that one should think about: activity versus accountability. So look for accountability, don't fund an activity. That is the first request to you. And the second is build models, fund models, capacities, which have long-term outcomes, not just a short filler gap, which is what most Indian philanthropists do.
So let me add my wish list to that. Unrestricted multi-year funding goes a long way to help the nonprofit world do what they can do best. Okay, so the Mackenzie Scott model gave a maybe not episodic but long-term funding, and then let the nonprofit decide how to use it is going to be a very good model. We, as I said, Arogya World, we are members of the India Philanthropy Alliance. They are experimenting, that coalition is experimenting with collective giving. I think that's a terrific idea. If we can join hands with other philanthropists and do it together, I think that makes a lot of sense. Collaborating on the ground in India for impact makes a lot of sense. So for me, one of the best ideas, someone came up to Arogya World and invited us to join, it is really fantastic. They're collecting a group of diaspora philanthropists here, but they have partnered with the government of India to find aspirational districts where a bunch of different nonprofits can do what they do best. So they can lift up the health and the education and the livelihoods of that one village or 10 villages, and that's works with the government of India's priorities as well, and it solves a lot of the regulatory issues that make all of us work harder than we should. But it is really a great model where there is on the ground work funded by philanthropists but in a coalition, so and where somebody else will ensure that the government is involved and that the programs get done and there's accountability, not just activity.
Love what you just said. So I happened, since you brought it up, I happened to be part of the Mission Karmyogi. It went from my desk. So when I was with the UN, I was posted in the ministry in the South Block, and which is the Prime Minister's office, and we designed that Mission Karmyogi, which is identifying the districts, the priority districts for investment, and health and education was the core focus in that. When Mission Karmyogi came out, it was really not just to see the competency-based, a placement of government officers, but to get them and identify nonprofits which are doing fantastic work at the ground in different states so that the government could partner with them and give funding without having them to go through those windows of procedures. So really a great point brought up by Nalini is look for those nonprofits who are doing great work. You will not go through the regulatory hassles. You will have no silo giving, but collective giving. And really, diabetes is the mother of all problems right now. So
Anyway, thank you very much, Seema. Thank you. I we have come to the end of the session, at least as we had planned. I do want to take 2 minutes to read out what we had called a Menlo Park Declaration. So a couple things, as I said, I feel today we've had an incredible array of speakers, and it has been, for me, extremely educational, inspirational, and, energizing. I got a jolt today. So, and I'm sure all of you did as well. Thank you for staying back beyond the time. We are doing two things to make sure there is some outcomes from this, okay? We have a couple Stanford students here who are taking notes to produce what we will call a proceedings document. We'll attach that. But we have also videotaped this, and we will be issuing snippets of this on social media as the weeks go on. But we have something which we are calling the Menlo Park Declaration that I want to read to you. It's a first draft. It's going to change completely in tone after today. But I think I want to we are putting a stake in the ground. We are saying we are going to call for something. We're going to stand for something. This set of diseases impacts us disproportionately, and we have to do something. We can't just sit still. This is who we are. This is very restless. It's a very big part of who I am. We're very restless, and so we want very much to do something more than just 50 people meet in a room, okay? So I'm just going to read this out. Okay. All right. Thanks. Thank you. Today, Saturday, 30th of May, 2026, in Menlo Park, California, we Americans, especially from South Asian communities, business leaders, physicians, researchers, philanthropists, and concerned global citizens who attended Arogya World Science Symposium, the next frontier in diabetes care, noted that people of South Asian descent are disproportionately impacted by diabetes and heart disease, as the Masala study has revealed. Knowing that 80% of these serious diseases can be prevented through 3 lifestyle changes, one must eat right, exercise, and avoid tobacco, several serious community-based efforts already here in California are helping people change behavior with tailored, culturally appropriate programs in India and in the United States. We will leverage technology, advances, and data insights from continuous glucose monitors and learn from lifestyle medicine and the breakthrough new medicines such as GLP-1 drugs. So we are going to lean on these new technology advances to help us combat the enormous risk for diabetes Indian Americans face. Philanthropy has a central role to play in the prevention of diabetes. And we commit, okay, here's a promise as well. We commit to doing all we can to lead healthier lives ourselves. That's the first pledge. Use our spheres of influence to help our families and communities, media, and policymakers appreciate that prevention is the smart solution to the chronic disease crisis America and Indian Americans face. And step up as leaders with our considerable reach and philanthropic dollars to make a meaningful dent in the trajectory of these very serious diseases. Because we must. Inaction is simply not an option. Okay, something like that. Okay, it's going to change. So I wanted to read it out to you because even though it'll change completely, we still want to make a public statement from this day today. Okay, this is so that people who are searching 5 years from now will remember this Menlo Park meeting. We'll remember this. We ourselves will, but so will all the others who read this statement. And this is a call to action to our community, to nonprofits, to partner, to philanthropists, to companies. There's a lot we can do if we put our minds to it. And the thing is, we cannot ignore diabetes anymore in South Asians. It's just not possible for me to sit at the edge and say, okay, I'm happy doing my programming. No, I think we can do a lot more than our programming. So let's all join hands. So one thing is that you will all be signatories in one way or the other. We will invite you. You can opt out. That's not a problem at all. But we would like to make a statement, and at a minimum, it'll be on our website. But it'll also can be on all your websites as well as on your personal social media. Okay. All right. Thank you, Rachana. We have taken 45 minutes more.
Okay. So we're almost done. I promise. We're almost there. We're gonna have our closing remarks by Dr. Date. Dr. Date is a global health leader, physician, and epidemiologist with over 20 years of senior leadership across public and private sectors. Her expertise spans medical and scientific affairs, clinical development, innovation, infectious disease and vaccines, epidemiology, real-world evidence, pandemic preparedness and emergency response, global health securities, I'm getting thirsty, women's health and health equity. She currently serves as a senior director of global medical affairs at Pfizer. Previously, she held global leadership roles at Johnson & Johnson and the CDC. She was recognized as Woman of the Year in Science by Women in Technology and as a top 50 women leaders in Atlanta and also the state of Georgia. Please join me in welcoming Dr. Kashmira Date.
Thank you, Dr. Reiki. I mean, this has been a phenomenal morning. I'm so energized, as Nalini was saying, and thank you for the kind introduction. I know I'm between everybody and lunch right now. Nalini, how much time do we have? Okay, so never mind. So all of these notes are going in that proceedings document. Okay, so fantastic. Again, I mean, I am just extremely energized. Nalini, thank you for putting this. And Nancy, this fantastic forum together. I feel like let me see what I can do in 2 minutes right now. But again, I'm going to take the time on behalf of Arogya World, I'm also an Arogya World board member, to thank all of our speakers, the panelists, the moderator, all of you here. The support has been phenomenal. I think we do need to take this beyond this group and really, the proceedings, not just that, but all of the messages that came out. I have just learned so much. It's just phenomenal. I'm an infectious disease physician, right? But the one thing that I always think about when we look at all of the risk factors, the impact, the outcomes, everything, all of these chronic diseases, diabetes is one of our top risk factors, the way we describe all of the outcomes from our infectious diseases. So when you have diabetes, when you have these chronic diseases, the impact of infectious diseases is much stronger, right? We know that the outcomes are worse, you get more complications, and all of those factors. So, I mean, again, I think this is something that we really need to emphasize, that sort of the cross-sectoral impacts that we have across all of these different areas. So I will say again, thank you again for your leadership, your commitment, everything that we've heard today. We have so many takeaway points. Like I made some notes, but I have like so much writing on this that I'm like, I need to, collect all of this information myself. But again, on behalf of Arogya World, thank you so much. This has been a phenomenal, phenomenal morning. That Menlo Park declaration, I think, was fantastic. I think you really summarized everything. We heard so many things that, we heard that now we can actually take this to action. What can we do to really make that impact, not just for ourselves, for our families and for our communities? Some of the things that I heard, communities as the quarterback, bringing all of the philanthropy efforts. Yeah, so I feel like this is really something that we can take down to our communities. The focus on youth, we heard so many things about how these impacts have started so much earlier than what we are used to thinking. So we have to take this down again to our, for our next generations. So, again, I mean, I feel like there is just so much I want to say, but I am going to take us now to, go and really assimilate all of this information together. So to all of our panelists and speakers, thank you again for your leadership and for your expertise. This has been phenomenal. To Nalini and the Arogya World team, thank you for your vision, for your persistence, and your leadership. This is really fantastic. To everyone here, thank you for being a part of this movement. I really hope that this leaves us today. We heard the declaration, but one insight, one connection, one commitment that we will carry forward. So again, thank you, everyone. Now, before we close, I'm just going to address a couple of logistics. Lunch is on the patio, right, Nalini? Okay. There is also going to be an informal roundtable discussion on different topics that we just heard about. So please, talk to all of the speakers. I know I've already identified a number of those I need to connect with. But again, please have lunch and join those discussions. For all of you coming in the evening for the gala, we look forward to seeing you there. So again, thank you very much.
About her Nourish program. So sit at her table if you want to learn more about what Chris Gardner said, Nourish. And then Meghna Gadgil, who's going to be talking about metabolomics, which is the study of the food habits of these Basala study participants. It's incredible. Ashwini Wagle has brought her book. So if you want to buy a book, please sit at her table. So there's a lot of great discussions still to have. Thank you.
Listen to Abbey Road. Watch all the colors run in a painted by Van Gogh, and it still wouldn't be half as beautiful as the way you make me feel.